Hello friends, in today's presentation I will be discussing about some basic tips for the fixation of Lisfranc injuries. I will be touching some basics that you must be aware before going to fix any such injury, their mechanism, their classification, their variations, some reduction tips and some fixation tips. So we'll be coming to all these points step by step. So before going to the presentation, you all must be aware that the first three tarsometatarsal joints are different from the last two tarsometatarsal joints because the first three joints are actually rigid joints. That means they have very limited motion. Therefore, you need to reduce them perfectly, because if the reduction is slightly compromised, then definitely the stability of the joint will be compromised, and the joint, which normally should not allow any motion, will become an unstable joint, and there will be some motion and the patient will present with long-term complications like pain and sometimes fixation failure. And then you all must be aware about the mechanism of injury, the classical signs that you see in the radiographs, and the classification as well. So let's start from the mechanism. So if you see the normal foot, this is the bony anatomy. You see all the metatarsals are aligned to the tarsometatarsal region at a particular angulation. That means you see this is an arc, and the roof of the arc is formed by the tarsometatarsal joints and the tarsal joints. So talus, navicular, cuneiform, they all are forming the roof of this arc. And whenever there is axial transmission of the force from the plantar surface towards this roof, there is definite tendency of injury in this portion. So the injury occurs like this. You see the metatarsals tend to subluxate dorsally, and their relationship with the cuneiform and the cuboid in the lateral part gets disturbed. You see the articular surfaces of the metatarsal bases has been exposed. It has migrated dorsally. So it all happens because of this particular anatomy and also because of the ligaments. The dorsal ligaments are very weak. Therefore, the tendency of subluxation occurs in this particular direction. This area is actually arched in axial plane also. That means if the metatarsals base are subluxating dorsally, they are actually subluxating laterally as well. But this is true only for the metatarsals which are on the lateral side of the first metatarsal. So the second metatarsal is actually on the top, and the remaining metatarsals are on the other side of the arch that is in axial plane. So they tend to subluxate dorsally as well as laterally. While the medial side, that means first metatarsal, may subluxate dorsally and medially because of the shape of the arch in the axial plane. So you see this is the injury pattern, and the injury pattern can vary from patient to patient. That means some patients may present with the injury to the lateral four metatarsals, and some may present with the injury of the first metatarsals, and some may present with the combined injury. This happens because the axial loading of the metatarsals can vary according to the loading at the time of injury. That means if the load was mainly on the remaining part of the metatarsals, not here, that means the injury is going to affect this part, the lateral part. But if loading was on the medial side, that means the injury may affect the first metatarsal. But if there was combined loading, that means there can be injury to both first metatarsals and the remaining metatarsals. From the anatomical point of view, these injuries are actually divided into two columns. The first metatarsal, medial cuneiform, and the navicular are forming the medial column. The second metatarsal and third metatarsal, along with the remaining cuneiform and the navicular, are forming the middle column, and the cuboid and the lateral two metatarsals are forming the lateral column. So injury can be classified according to the column affected as well. So in this picture, we are seeing the injury to the middle column and the lateral column. The medial column appears to be relatively intact. So this is the normal contour of the tarsometatarsal joints, and this is the contour which we see whenever there is a Lisfranc injury. And you see this small fragment here. That fragment is actually representing the avulsion of the Lisfranc ligament from the second metatarsal, which is also known as flex sign in radiographs. I'll be showing you in the coming slides. So the criteria for the diagnosis of Lisfranc injury has certain points on the radiograph. So in radiograph, you must see that the space between the base of first metatarsal and the second metatarsal should either be minimal or should not be visible in AP view at all. Whenever there is a doubt, you can get a radiograph from the contralateral side as well. So this is in the AP view. Second thing, the medial part of the second metatarsal should articulate with the medial part of the middle cuneiform. You see this is the medial cuneiform, this is the middle cuneiform, and the medial part of the second metatarsal is in line with the medial border of the middle cuneiform. These are the findings normally we see in AP view. And in oblique view, what we see, First thing is that the first metatarsal, the medial cuneiform and navicular should form a single line. The medial border of the first metatarsal, medial border of the medial cuneiform and the medial border of the navicular should be perfectly aligned like this, as we see here. And the medial border of the fourth metatarsal should be aligned with the medial border of the cuboid. So this appears to be normal, and there should not be any subluxation of the fifth metatarsal base over the cuboid. Often this finding is difficult to identify because normally the fifth metatarsal is slightly proud of the cuboid. But in case of injury, this proud part becomes more prominent, and it is often difficult to quantify whether it is subluxated or not. So what you can do, you can simply see the joint congruence. So fifth metatarsal should be in contact with the fourth metatarsal, and there should be uniform joint space throughout this joint. That means the fourth metatarsal base and the fifth metatarsal base should be perfectly congruent to the articular surface of the cuboid like we see here. Then in the lateral radiographs, we should prefer the weight-bearing radiographs because often the dorsal subluxation is actually the sign of instability. It might not be evident whenever the patient is not bearing the weight, but the moment the patient bears weight, there is dorsal subluxation of the injured metatarsal base. So we should order these weight-bearing radiograph lateral views. So here we see there is no dorsal subluxation. We have to see the contour of the cuneiform bones, and there should not be any distortion in this region. That means there should not be any prominence of the metatarsal base in this region. If there is some evidence of such prominence, then we should better get a CT also to better assess the injury. So these are the normal radiographs. Now we will see the injury radiographs. So here you see this is the AP view, and the space between the first metatarsal and the second metatarsal is increased, and sometimes we see a small fragment here which is actually the flexine, which represents the avulsion of the Lisfranc ligament. The actual Lisfranc ligament is the ligament originating from the lateral side of the medial cuneiform and inserting over the medial side of the base of the second metatarsal. So whenever there is an avulsion, we see bone fragments in this zone. Here we see some commission in this zone. Also, the medial border of the second metatarsal is not articulating with the medial border of the middle cuneiform. So there are definite signs of Lisfranc injury. In oblique view, we see that the medial border of the fourth metatarsal is not in line with the medial border of the cuboid. So that means it is subluxating laterally. And the fifth metatarsal, we see there is prominence here, and also if you see the congruence of this joint is lost. That means the articular surface of the fifth metatarsal is somewhere till here. You see there is a smooth part here, then there is a prominence. So it is definitely outwards compared to the articular extent of the cuboid. So there is clear-cut sign of Lisfranc injury. And in this lateral view, you see there is some distortion of alignment in this zone. So this part is representing a cuneiform bone. You see here. You see there is a prominent margin which represents base of some metatarsal which is subluxating dorsally. In this view, we can't comment which metatarsal base it is, but definitely the injury can be confirmed. So for better assessment, we need a CT. Like we have seen in the previous image, the 3D CT was shown. Now coming to the classification. So I've told you we can either quantify the injury pattern according to the columns. So here all columns are injured, here also all columns are injured. Here we can say it is only the medial column, here also we can say it is only the medial column, and here we can say it is the lateral column and the middle column. Here we can say it is the medial column and the middle column. Here again we can say it is medial column and the middle column. And here we can see it is affecting all the columns, and here also we can say it is affecting all the columns. Now the other classification, which is given by Hardcastle and Meyerson. I won't be going into details of this classification because it's mainly the pictorial representation. You can see all the types A, B and C. In type A there is total incongruity, in type B there is partial incongruity, and in type C there is divergent pattern. So you can all see in the images. There is no point of discussing it in detail because we have already discussed the mechanism and column based classification. Now coming to the example. So this is the total incongruity. So the displacement can either occur at the tarsometatarsal joints but can also involve whole of the cuneiforms. That means a variable number of cuneiforms may remain attached to the metatarsals and then displaced in lateral or dorsoplantar direction. Here in this example we see whole of the assembly of the tarsometatarsal joints. That means the articulations of the first metatarsal with the medial cuneiform, and the second metatarsal with the middle cuneiform, and the third metatarsal with the third cuneiform as well as the remaining metatarsals are subluxating towards the lateral side. You see the articulation of the middle cuneiform is not at its normal place with the navicular. The navicular is here and whole of this segment should have been here. But in this X-ray, it appears to be displaced towards the lateral side. So this is a total incongruity kind of picture, and it will be a lateral subluxation. And in case the cuneiform would have been lying here, the injury would have been at the metatarsal basis. But here it is involving the block of the metatarsals and the cuneiforms. And this picture, in which there is partial incongruity, we see there is injury to the middle column only. So this is type B1, which is affecting the middle column only. You see the first metatarsal base is subluxating medial side and the dorsal side, while the remaining parts, that means the middle column, the base of the second metatarsal is still articulating with the middle cuneiform, and in oblique view, the base of the fourth metatarsal is still articulating well with the cuboid, and there is no lateral subluxation. We see a good congruent joint in this place. So this is a kind of type B1 injury. And in type B2 injury, that means middle column and lateral column or isolated middle column is affected. Here we see there is injury to this column only, while the medial column is intact. So that means this is a type B2 injury affecting middle and the lateral columns. In this picture also you see there is injury to the middle and the lateral columns. They all are subluxating towards the lateral side. In type C, we have divergent injury. There is injury to the medial column as well as the lateral column, and both are going in opposite direction. Here we see, although there is not an obvious injury to the first metatarsal and cuneiform joint articulation, but whole of the medial cuneiform is disrupted. It has subluxated medially. And for the middle and lateral column, they are subluxating towards the lateral side. So this is kind of C2 picture in which we have injury to the medial column and the lateral plus middle column. So I hope the classification part is clear. Now coming to the surgical methods. For surgical methods, we can go either percutaneous fixation or delayed ORIF or arthrodesis. That means for cases like in which there is extensive soft tissue injury, like in case of contaminated wounds, compartment syndrome, we can definitely go for a temporary measure like placement of multiple K-wires in an approximate anatomical reduction. And later on, when the soft tissue condition improves and the compartment syndrome part has been managed, we can go for delayed ORIF. That means we have to reduce the joint perfectly, then fix it with screw, K-wires or plates as per the situation demands. In cases where the soft tissue condition is good, we can definitely go for primary reduction and fixation. That can either be open or percutaneous, but the fixation has to be a stable one. And some authors advocate for primary arthrodesis of the first, second and third metatarsal joints because they have limited mobility and they cannot tolerate any malreduction. Therefore, they advocate for the arthrodesis of these joints. But in my opinion, if you are sure that reduction is perfect, then definitely you can go for fixation and not the arthrodesis. But if you have slightest doubt that the joint is not perfectly restored, then definitely go for fusion of the joint. So in my experience, whenever you are preferring close reduction, always get accurate reduction and fix it with rigid fixation. That means either you can use a screw or a plate, and if you are using K-wires, they should be thick one. And whenever you are fixing with K-wires and you need more stability, then definitely you can definitely supplement it with an external fixator as well. That will add to the stability if you are using the K-wires. And the open reduction has to be preferred whenever you are not getting good anatomical reduction. Then you have to reduce the joint under direct vision, and you can fuse first to third tarsometatarsal joints. And whenever the anatomical reduction is not visible, then definitely you have to go for the fusion, because slightest incongruency can result in abnormal motion in these joints. So first to third tarsometatarsal joints need to be fused if the reduction is not good. And also in cases which are having delayed presentation, often to clear up the joint you need to remove the fibrous tissue, and then you are not sure whether you have reduced the joint perfectly or not. Then in those cases also you should prefer fusion. So the first three tarsometatarsal joints should be fused, while the fourth and fifth tarsometatarsal joints can be fixed with K-wires also, because they are normally the mobile joints. They allow some motion and you should not fuse those joints. And if you are putting screws, then you have to remove those screws after healing of the injury. And the evidence is in support of both fixation as well as fusion. There are papers which say that the fixation is sufficient, and there are papers which say that the fusion is having better outcomes. But the only obvious advantage of fusion is that it does not require the implant removal in most cases, because implant related irritation occurs in the mobile joint. So whenever there is some motion at the joint, then definitely the implant will gradually loosen up and result in irritation. But in cases when the joint is fused, the implant will remain stable at its position. So the implant or hardware related issues are less in fusion. Now starting with the basic anatomy, which you all should be aware before going to fixation. So as I told you earlier, that in axial plane, the tarsometatarsal joints are forming an arch. So the medial column, that means the base of the first metatarsal and the medial cuneiform, is at a lower level, while the top part is formed by the second metatarsal, which is articulating with the middle cuneiform as well as medial cuneiform, and some part of the third cuneiform or lateral cuneiform as well. So it is actually entrapped between all these cuneiforms, and the remaining metatarsals are at a lower level compared to the second metatarsal, and they are on the lateral side of the arch that is formed in axial plane. Therefore, subluxation of the medial column occurs in this particular direction, while the subluxation of the lateral metatarsals occur in this particular direction. That means they subluxate laterally as well as dorsally. Now coming to the ligaments. So the dorsal tarsometatarsal ligaments are on the dorsal surface, while the plantar tarsometatarsal ligaments are on the plantar surface of the tarsometatarsal joints. The plantar ligaments are strong ligaments and they are rarely injured, while the dorsal ligaments are weaker ones. Therefore, the subluxation occurs in the dorsal direction. And then there are intermetatarsal ligaments, which are there in between the bases of all the metatarsals. While in case of second metatarsal, the intermetatarsal ligament is absent. Therefore, the second metatarsal is actually prone to this injury. In place of the intermetatarsal ligament, the second metatarsal base is actually attached to the plantar and lateral aspect of the medial cuneiform. The medial cuneiform should be somewhere here, and this part actually represents the Lisfranc ligament. And whenever there is injury or opening up of this space, we often see a fragment attached to this ligament is actually representing the flex sign, and that is pathognomic of Lisfranc injury. Now coming to the close reduction. So now I've told you that the subluxation of the lateral metatarsals occur in dorsal direction and the lateral direction. So what you need to do, you can simply give traction to the one or two metatarsals. That traction will bring the metatarsals in a proper length, because only the dorsal ligaments are injured while the intermetatarsal ligaments on this side are still intact. It means any movement that you are going to transmit over this metatarsal is automatically going to be transmitted towards this part also. But if there is injury to the intermetatarsal ligaments also, then you can individually give traction to each metatarsal. So this is the axial picture of this kind of subluxation. You see, second metatarsal is not aligned with the first metatarsal. It is coming off in this direction. That means dorsal as well as laterally. By giving the traction, you will be able to achieve length. You can simply give a push from the dorsal side towards the plantar side. So that will actually push the metatarsal bases towards their articulation with the cuneiforms. And if the intermetatarsal ligaments are intact, the reduction of one metatarsal will automatically bring the reduction of the adjacent metatarsal. So this will be a sequential process. That means if you reduce the second metatarsal, that will automatically reduce the third metatarsal. And if there is some injury to the intermetatarsal ligament, then you can go for a separate procedure for each metatarsal as well. So this will be the picture after we give a push along with traction to the metatarsals. By that, we will be able to reduce the dorsal subluxation. But often the lateral subluxation still persists. That means you are able to get this metatarsal downwards towards the cuneiform, but the increased space may still persist. Then for that, you can simply use a clamp, and by that you'll be able to reduce their opened up space. You can simply place a nick over here and then feel for the bone, then pass the clamp directly over the bone over the base of the second metatarsal. Then compress this towards the first metatarsal. So here is the fluoroscopic image. You see, we have got the proper length of the metatarsal. We have reduced the cuneiform and metatarsal articulation, but there is still increased space in the zone. Then what we did, we placed an artery forceps over the base of the second metatarsal just to know where we should put the clamp, and then made a small nick over this part for the placement of the clamp. And this metatarsal has to be compressed toward the medial column. So one end of the clamp should lie over the base of the second metatarsal lateral side, and other end of the clamp should lie over the medial cuneiform. Alternatively, if you feel that this part is injured and placement of clamp over this bone can fracture the cuneiform, then what you can do, you can place other limb of the clamp over the base of the first metatarsal, because that will also bring the second metatarsal towards the medial column, and we have to reduce this space. In this fracture also we see a small fragment here that is actually avulsion of the Lisfranc ligament. This is again the flex sign. But in resistance cases, suppose you have tried to gain the length, but by gently pushing with your thumb, reduction is not happening. So this kind of picture we are getting. That means this is the cuneiform bone and this is the metatarsal, and this has subluxated dorsally and it is not reducing. This problem is faced whenever the case presentation is late. So what you can do, you can simply place a blunt instrument inside the joint under fluoroscopy guidance. Here we see we have placed a small mosquito artery forceps inside the joint, then lever the subluxating metatarsal towards the plantar side. Like I've shown you here, this artery forceps is inside the joint. It is taking the support of the cuneiform to reduce the subluxating metatarsal towards the plantar aspect. So by doing that maneuver, we will be able to reduce the metatarsal towards the plantar side. And the moment we have reduced the dorsal subluxation, then we have to focus our attention towards the increased space between the second and first metatarsal. For that, we have to place a clamp over the lateral side of the base of the second metatarsal, and one arm of the clamp is towards the medial column. Then we'll be able to reduce this increased space. In the lateral view also, we see that the dorsal subluxation has been restored. This is the first metatarsal and this is the second metatarsal, and it is well aligned with the cuneiform bones. There is no evidence of dorsal subluxation now. So this was the initial picture. You see there was increased space, and after reducing the dorsal subluxation and placement of a clamp to reduce this increased space, we are able to reduce this second metatarsal perfectly towards the medial cuneiform and the first metatarsal. And also, since I told you earlier that these metatarsals are actually attached with each other with intermetatarsal ligaments, so reduction of one metatarsal automatically brings the reduction of the other adjacent metatarsal. If you see here, the joint space was not uniform. So you see here the joint space on the lateral column and base of third metatarsal was not congruent with their respective tarsal bones. There is definitely some irregularity seen here, and here also you see some irregularity is there. But after reduction of the second metatarsal, we see the joint space is now becoming more congruent compared to this part. Now for open reduction, what you can do, if it is isolated injury to the medial column, then we can give an incision directly over that particular joint. We can give an incision directly over the base of the first metatarsal, then avoiding any injury to the long extensor tendon and the neurovascular structure that are lying towards the lateral side of the first metatarsal. We can go and expose the joint here and reduce the dislocation or subluxation under direct vision, and then fix it with the screws or KYs as per the situation demands. If there is injury to the medial as well as middle column, then we can give an incision over the first web space. By that we'll be able to simultaneously address the injury to the second metatarsal as well as first metatarsal. And we have to avoid injuring the short extensor tendons which are crossing obliquely this plane. We have to detect them, then we have to expose the joint if required. In case of injury to all the tarsometatarsal joints, we can give separate incision to address at least two tarsometatarsal joints with one incision. So we can give incision over the web space between the fourth and fifth metatarsal and the second and third metatarsal, and on the medial side of the first metatarsal to address each injury component. In most cases, two incisions are sufficient because the fifth metatarsal rarely requires an open reduction. It automatically comes in place after the remaining metatarsals have been reduced. So conventionally, these two incisions over the first and the third web space are used to address multiple column injuries. So for isolated injury, an incision directly over the joint can be given, and then reduction under direct vision can be done, then secured with multiple K-wires, fixed with screws, and supplemented with external fixator if required. And in cases when there is injury to the multiple columns and the close reduction is not feasible, then we can definitely go through the web spaces, and in one web space we can definitely address two adjacent metatarsal bases. We have to avoid putting an incision directly over the tendon because that may result in adhesions and may limit the motion of those tendons and result in contracture later on. So that kind of incision has to be avoided. It has to be given in a space which is clear of the tendon. Now the dorsal subluxation can occur at any metatarsal base, and the residents are often concerned whether we have reduced the base of each metatarsal perfectly or not in lateral view, because in lateral view there is crowding of the metatarsals and we are not sure whether the base is perfectly aligned with its tarsal bone or not. So what we can do, we can get sequential oblique views to see whether each metatarsal is perfectly articulating with its tarsal bone or not. So what we can do, we can start from this point. So this is the fluoroscopy console and the limb is positioned in a figure of 4 position. So now the medial and lateral aspect of the foot are in line with the fluoroscopy beam. So this is the direction of fluoroscopy beam. Then we have to lift the heel in such a position so that the first metatarsal is now coming on the top of all remaining metatarsals. By that we'll be seeing whether the first metatarsal has dorsal subluxation or not. Then we can simply lift the knee up gradually so that the second metatarsal will now come in line with the fluoroscopy beam and first metatarsal will come downwards in relation to the second metatarsal. By that we'll be seeing whether the second metatarsal is articulating perfectly with the middle cuneiform or not. Then we have to lift the knee further up. By that we'll be able to see the top part of the third metatarsal base, and then by doing this step further, that means lifting the knee up, we'll be able to see the lateral metatarsals as well, because the fluoroscopic beam will now show the top part of each metatarsal. I'll show you with the example. So the first metatarsal is having the widest base on all metatarsals. So we have to see a view in which this metatarsal, the widest one, is coming over the top of the other metatarsals. So here we see it is coming over the top of the other metatarsals and is aligned with the cuneiform. So there is no subluxation of the first metatarsal in the lateral view. Then by lifting the knee slightly up, we are bringing the second metatarsal toward the fluoroscopic beam. And you see here, the first metatarsal has now come downwards and we are seeing the second metatarsal. It is articulating well with its cuneiform. Then by lifting the knee further up, we are bringing the second metatarsal a bit down and we are now seeing the third metatarsal. You see, this is the third metatarsal. It is articulating with its cuneiform. And then by lifting the knee further up, we are able to see the fourth metatarsal. You see this line is the fourth metatarsal articulating with its respective tarsal bone, that means cuboid, and there is no sign of dorsal subluxation. And then by lifting the knee further up, we are able to see the fifth metatarsal, which is articulating with the cuboid, and there is no sign of dorsal subluxation. So by checking this sequential oblique view in figure of 4 position, we can check whether each metatarsal is perfect in the lateral view or not. So if there's any distortion and sign of prominence in this part in any of these sequential views, that means there is residual subluxation and that needs to be addressed in that particular view only. So this sequential oblique view will be helpful for you whenever you are addressing these injuries to see whether all the metatarsal bases are perfect in lateral view or not. So now coming to some examples. Now here you see it is injury to the medial column only, that means type B partial. So this is type B1, that means medial subluxation and partial incongruity. The remaining metatarsals are still aligned, that means the second metatarsal is aligned with the middle cuneiform, and in oblique view the fourth metatarsal is still in line with the cuboid and there is no evidence of incongruity in the cuboid and the fourth and fifth metatarsal bases joint. So it is isolated medial column injury. Now the patient had a delayed presentation. So in these cases, we are not sure whether the joint reduction is perfectly anatomical or not. So it's better to fuse it. So the procedure of fusion was performed and headless compression screws were placed and it was supplemented with an external fixator to add more stability. So this was a follow-up radiograph. You see there is evidence of bone formation here, and if we zoom in, we see there is trabecular continuity in this plane. That means the fusion is successful. So I've told you for these 3 metatarsals, it's better to fuse if the reduction is not anatomical or in cases with delayed presentation. 2 screws are sufficient, and if you want more stability, then you can definitely supplement the fixation with an external fixator, or you can use additional screws also if required. And in this case, you see there is total incongruity. That means whole of the block has subluxated towards the lateral side. What we did, we reduced this displacement, and once the radiological parameters were restored, then we placed multiple K-wires through the affected joints and supplemented the fixation with a fixator over the lateral side because there was tendency to subluxate towards the lateral side. In this example, you see there is combination in this zone and the screws may not be sufficient, so it needs an additional stability. It's operated by one of my colleagues and he placed a plate over this zone because whenever there is doubt about the stability, definitely a rigid fixation is preferred. So plate will be helpful in such a scenario. And you see he has placed screws through the first metatarsal cuneiform joint, placed a plate spanning the second metatarsal joint, and placed a screw over the third tarsometatarsal joint. So this part needs to be fixed with a stable fixation, while this part, if injured, can be fixed with the K-wires also. So the brief take-home message of this presentation would be that the accurate reduction is the key. You have to follow the radiological signs of Lisfranc injury to restore them to normal, and whenever there is doubt, get a CT also, like I've shown you in the 3D images. The 3D images give a better picture, so always get a 3D reconstruction view also, and check all the oblique views which I have told to avoid any dorsal subluxation. And open and closed reductions are equally good, but the reduction should be accurate, and the stable fixation should be done either with screws, K-wires, thick K-wires should be used, and whenever there is doubt, use an external fixator also, and plates can also be used to supplement the fixation. Whenever there is doubt about the reduction, go for the fusion of the first 3 tarsometatarsal joints. I will be soon adding a video on fixation part also. Thank you.